big.
Yeah, I know.
And
The
you know,
growing uterus, I know the
yeah,
problem.
well, it basically gets rid of the bleeding, which is the primary reason to have hysterectomy.
Yeah. Yeah, I haven't had that, but I've had the growing uterus.
Yeah, if it grows and doesn't,
Exploding
if
uterus.
it grows and doesn't bother you, forget about it.
I know. You can't really tell, but boy.
Can't tell.
Yeah, I don't know. I can't really tell too much, but it's definitely growing.
Doesn't matter.
Doesn't make it?
Doesn't
Okay.
matter. It grows real big in pregnancy too. As long as it doesn't bother you, leave it alone.
But I don't want it to look bad
It
when it
won't.
starts to show.
It won't.
It's history, as they say. All right. Okay. Well, maybe we could just talk a little bit about the history of this. And just as you were telling me now, you started doing this so many years ago, and tell me how it's progressed.
Okay. Basically, endometrial ablation is something that was thought about for many years, ever since a man named Asherman described a group of women who had a D&C after an abortion or after delivery and didn't menstruate anymore. That was thought to be a rare condition when Asherman described it in the 40s. But people recognized that it would be of great benefit if they could duplicate it, because there are a lot of women who suffer from excessive uterine bleeding, and it's the primary cause of hysterectomies in the United States and probably the world. I decided to use the laser in 1979 because I understood it. It could be done through a small instrument called a hysteroscope, so we could see what we were doing. And so in 1979, January of that year, we did our first patient, and she was successful. And since that time, we have done over 500 patients, all for excessive and disabling uterine bleeding, and we've had a success rate of about 97%, meaning that of those patients, about 70% never bleed anymore, and 30% will spot for 1 to 3 or 4 days with each menstrual period. Both groups are very satisfied. The procedure has been fortunately successful from the beginning. It is extremely low in complications, very minimal, and we've had no serious complications. The procedure is, we still do the procedure as I initially did it. Some modifications as far as the amount of fluid we use during the procedure and so forth. But we realized that it was sort of a tedious procedure, and people have now started to do a procedure with electrosurgery, commonly known as a roller ball. It has worked very well. I don't think the results are quite as good as the endometrial ablation with the laser, but that may be a matter of a learning curve. In other words, as you start doing new procedures, it may not do as well as the old one until people become more proficient. But the roller ball uses an electrical current to destroy the endometrium. There are some advantages of the laser over the roller ball in that we've had a lot more background in it. There's a higher incidence of amenorrhea, no periods, and the better understanding of the laser as an energy source than electrical surgery. But now electrical surgery seems to be standardized and seems to be quite safe.
I think we got several bites in there I think we can use, Dave.
Yeah, we're at the ball, and they've all had a couple of martinis. Yeah, we're worried. Well, they're going to use this for other purposes too.
Okay.
So,
Yeah, that one, and then to talk about the rollerball procedure again in 10 seconds or
Okay.
less.
All that in 10 seconds can't do it.
Yeah, no, I know.
Yeah.
No, not the rollerball, but just
Okay.
the part about
All
the ablation, perhaps in
Okay.
10 seconds. Wow.
All right. Endometrial ablation is a procedure to stop menstrual periods when women are bleeding excessively. We at Sinai decided to use the laser because it could be done under direct vision. We could see what we were doing through a small instrument called a hysteroscope. Since that time, in 1979, we have done over 500 patients with a 97% success rate. Of those successful patients, 70% never bleed again, and the other 30% will spot for 1 to 3 or 4 days per month.
Okay, and then we should talk maybe just ever so briefly about the rollerball procedure.
Endometrial ablation has of late been done with electrosurgical procedure, commonly known as the rollerball. The idea behind that is the energy source, instead of being light as it is in laser, is an electrical current. The electrical current destroys the tissue under direct vision, much as the laser does. It is a different modality, and up to this present time, the results have not compared with the laser, but in the future they certainly might.
Bingo, I think we got it.
Okay?
Yeah.
Phone. Okay. We started, it's a learned experience when at birth and during the early childhood. Involuntary incontinence is the usual sort of mechanism for voiding. A little urine collects in the bladder and boom, it's an involuntary sort of expulsion of urine. The process of continence is a learned experience which becomes subconscious in most people. There are some people who continue to have incontinence throughout their life to some extent, some to a greater degree and some to a lesser degree. And some remain incontinent during nighttime. Adults who will continue to be involuntary incontinent at night. So the process of continence is one of a learned sort of thing, and becomes a reflex and subconscious as to how we retain fluid and urine in the bladder. First of all, you have certain mechanisms that you have to allow for. You have to have a bladder that will expand and allow the pressure to expand. So you have to have a relaxation of the smooth muscle here without contractions. As you know, in the uterus, as the uterus expands during a pregnancy, there is contractions going on, but we have a mechanism there for decreasing that, and that's the high dose of progestins would interfere with the uterine contractility. We don't have anything like that in the bladder. We allow this to increase, and the regular pressures in the bladder somewhere between 10 and 15 centimeters without triggering off a contraction of the bladder, and that the bladder can then fill, that's at normal pressures, but then you can put in 300, 400, and 500 cc of urine in here and allow that bladder to expand without triggering off a contraction. And you have two mechanisms involved. You have the relaxation of the bladder to accommodate the urine, and you have a constricting force at the urethra opening here. Now, pure plumbing experience will tell you that urodynamics is that if this pressure is higher than the pressure in this tube, it's going to come out, right? It's going to come out. So, and it's unavoidable. So you have to maintain, in order to maintain continence, you have to turn the urethra angle here to maintain that continence. And when you lose it, there's two things that are things. The pressure here overcomes the pressure at that point. Now, what are the mechanisms which allow this pressure at this point? Well, you have, as you know, the fibers that come off from the levators and the pubococcygeus and so on, continue down, and there's the sacrouterine ligaments, laterally come out as the cardinal ligaments, pubocervical ligaments come down here, and sacrouterine, which we didn't put the sacrum in here, but come in this way. And then the fibers will continue on down under here and between the rectum and the vagina. Now those, when the levator contracts, all these structures have to be lifted. And when there's these ligaments here, these fibers coming off the fascia, which are attached to the bone here and back to the iliac crest, they're going to lift this and put tension on the here and create this angle and create a high pressure in the urethra. And that holds that, and plus the fact that that the bladder expands to hold a considerable amount of urine. Now, the act of avoiding, what happens? One has to allow first of all, the levator has to relax. So you allow the levator to relax, so this allows this angle to suddenly become funneled or straight across, opening it sort of, which allows the decrease in pressure here, and the bladder, the detrusor muscles contract and increase the pressure here and forces the urine out. Okay, and the opposite is
Okay. Important thing in this situation, we have a patient that had a previous cesarean section and we're allowing her to go through labor. We've already checked to make sure that it was a lower transverse cervical incision, and we have to watch her a little closer than the average patient in labor because of the scar in the uterus. Why is she on magnesium sulfate?
Well, she came here with premature contractions, and they had difficulty to control the contraction with terbutaline, and she ended up to be on magnesium sulfate that has been able to control her, but she's still contracting about 10 minutes.
Obviously, despite what the textbooks say about this situation, the patient's requests have to be honored, and the most important thing is that she understands all the facts so that she can make an appropriate decision.
Yeah, all the possibilities and possible complications have been explained to her, and the fact that the vaginal delivery is more safe, but is safer, but she still insists to have a repeat cesarean section.
Why did she have her first section?
For CPD, cephalopelvic disproportion.
And this baby looks smaller than the previous one, or bigger, or about the same?
I would guess about 7 pounds, not a very big baby.
Okay. And her blood pressure's okay?
Everything has been stable.
And the other-
Vital signs have been under control.
Okay. Do we have a recent ultrasound?
The last one was about 25 weeks.
And we know that it's a cephalic presentation,
Yes.
and there's no anomalies that we know
Yesterday she has been checked for that, and she's cephalic presentation.
of. Okay. I think that's real fine.
Need a little bit more.
All right, why don't we talk about his status?
Okay. Well, the problem here is that I don't want to get those names involved. Now, tell me a little bit about the patient that came in last night. Had some chest pain, and
Oh, we had a patient that. We're talking about how this was.
yeah, well, just don't mention any.
We had a patient that came here with history of chest pain for the last 2-3 days. That they got worse yesterday on the right side of her chest, and with complaints of shortness of breath and tachycardia. She's about 24 weeks pregnant and previously has been healthy with uncomplicated pregnancy. When she was brought down, when she was seen by the EMS in her home, her blood pressure was about 53/30s. And they started IVs on her, and as much as they could stabilize her and brought her here. When she arrived here, immediate ultrasounds showed that the baby had good heart tones and was safe. She had history of placenta previa. There was no evidence of abruption, so baby was safe. Mother's evaluation revealed that she was hypovolemic. Immediately, arterial lines and venous lines were started, and portable chest X-ray that was performed revealed collapse of the right lungs and some opacities over the left line.
No problems before with this pregnancy.
Previously, patient has been completing uncomplicated. That's her first pregnancy. The thoracic
Excuse
surgeon
me,
was
she's how many weeks pregnant, did you say?
25 weeks pregnant. The thoracic surgeon was involved at that moment, and he performed a thoracentesis that revealed bloody fluid. Immediately, with the diagnosis of possible hemothorax, a chest tube was placed, that drained about 1.5 liters of blood from the pleural space. Previously, patient had been intubated to improve her oxygenation, and subsequent chest X-ray that was performed revealed partial expansion of the right lung, and her requirements for the O2 replacement were decreased. She was oxygenating better, and due to the subsequent signs of fetal distress that were apparent on the fetal heart monitoring, she was sectioned and the baby was delivered. Baby apparently is doing fine.
Now, why was she sectioned?
Because the patient was put on the baby's heart rate had been continuously monitored down here as we usually do.
She had fetal
And,
distress at
signs
26
of
weeks?
fetal bradycardia developed. And
Didn't they think that when they stabilized her vital signs that her fetal distress might disappear? Did they think it was secondary to the maternal?
At the beginning, the decision was, since the mother seemed to be more stable, to not to deliver the baby because of the significant prematurity at 25 weeks. But subsequently, in spite of the stabilization of the mother's situation, since the fetal distress developed, and we couldn't ignore that, and there was no specific etiology to be corrected, the decision was made to go and to deliver the baby.
Probably also. Well, the diagnosis of choriocarcinoma probably wasn't entertained at that time, or was it?
There was a question, but there was really no, it wasn't a clear idea until the placenta was delivered and we received the results of beta HCG that were significantly elevated up to about 500,000 units.
What did the placenta look like?
I wasn't present at that time, but apparently it looked abnormal. But we are waiting for the pathologist's results to give us exact, accurate diagnosis.
Was there evidence of invasion of the uterus from the placenta or any other pelvic structures?
There has been there was invasion of the uterus, but they have been able to separate the placenta and control the bleeding. So apparently the invasion.
Can I have a knife and
You gotta step out of the way, because I don't want to get close enough to let you
We're
do
going
it.
to be, in the laser, we're probably the laser right over here. Okay. So probably a good shot would be just back like this, you'd be able to see him holding the laser. Okay. You know, just like, you know what I mean? So we're gonna put the laser right, you know, this is going right in here.
You guys do that right now?
Yeah, we're not yet, we'll show you what we're gonna do. Whatever shot you want.
you see here, it shows me hooking up instruments from below, and general says putting some needles in, putting a victoral card in, skip all that. Take your picture. Then you'll have pictures that look like what you see on the screen.
Yeah, like that picture.
That's fine. Now, the stuff that's on the screen, there's 3 separate things. If I explain them to you, I think you'll be able to remember. One, what I'm going to be doing is Luna procedure, which is what I devised. You're going to see something that looks like an inverted V, and the laser cutting the top part of it. That's the procedure. Number 2, you'll see that there's a needle going in and draining a cyst. No big deal. Third one, you'll see something that looks big and red at the end of the tube. Then you see using some lasers and scissors and cutting, and then you see the blue come through. And that's infertility work. Blooding will start to tube. I'll give you a 30-second overlay, and then you can mix it with that as you want to.
Yeah, okay,
And that should make life really easy.
that'll work out real well.
All right, and that's all. It's just like you want a modern picture of what things are. You can see things that have changed in 6 years. I know if you want to see all the technological instruments you see with a big wide-angle view, may be interesting for your video. And that's what if you could back up and you have a panoramic view,